Greetings, I am Nityal Kumar, lecturer from JSS College of Physiotherapy, and today's topic is complex regional pain syndrome. You might be knowing complex regional pain syndrome is a neuropathic condition where it affects both upper limb as well as lower limb. And today's contents will be definition, epidemiology, causes, clinical features, taxonomy, pathophysiology, diagnostic test, and management has been divided into three components: medical, invasive, and allied. And at the end we will see evidence of each management. And when it comes to definition, it is a syndrome that usually develops from a non-noxious stimuli and is not limited to distribution of a single peripheral nerve. So when you see there is going to be a pathology of a trauma, and a patient will be having something called as an inciting event. And this neuropathic pain is not only for a single peripheral nerve distribution, it is going to be throughout. And this will be disproportionate to the inciting event. So whatever area of injury initially a person is having, but now the area of his pain is going to be more than the inciting area. And the other thing is, it is also associated with some point of edema, changes in skin blood flow, abnormal pseudomotor activity in the region of pain or allodynia. So allodynia is a process where a person is going to perceive a non-noxious stimuli as a noxious stimuli. And it was done by Marzak and Bodok in 1994. When it comes to type, the International Association for Study of Pain has proposed into CRPS into two types based on the presence of nerve lesion or absence of nerve lesion. When it comes to type 1, formerly known as reflex sympathetic dystrophy, which doesn't have any sort of a definitive nerve lesion. When it comes to type 2, it is known as causalgia and it has a definitive nerve lesion. So now the types is CRPS type 1, traditionally known as RSD or oligodystrophy, and CRPS type 2 is causalgia with a definitive peripheral nerve injury. Synonyms of CRPS is, it is otherwise called as reflex sympathetic dystrophy, that itself shows the overactivity of sympathetic system, and it is otherwise called as causalgia, Sudeck's dystrophy, and shoulder hand syndrome, and regional migratory osteoporosis. When it comes to epidemiology, there is an article done in 2011, published in Indian Journal of Plastic Surgery. The incidence of CRPS is 5 to 26 of 100,000 population, and some epidemiological features are: women are more prone to get CRPS than men. Incidence increases with age until 70, and upper limb is more prevalent than a lower limb. So this means both upper limb as well as lower limb is going to get affected with CRPS. And of CRPS type 1 and type 2, CRPS type 1 is more common and it is around 90%. When it comes to causes, there are multiple causes for a person to end up in CRPS or neuropathic pain, and peripheral musculoskeletal causes, peripheral nerve or dorsal root causes, and central nervous system, viscera, and idiopathic. These are some of the causes a person is going to end up in chronic complex regional pain syndrome. And from peripheral musculoskeletal, fractures account 45%, sprains around 18%, elective surgery around 12%. And of elective surgery, total knee replacement, distal and radius fractures stabilized by internal fixation, open reduction internal fixation particularly is one of the areas where a person is going to end up in complex regional pain syndrome. When it comes to other causes in peripheral musculoskeletal, it is dislocation, immobilization, fasciitis, tendinitis, arthritis, mastectomy, and DVT. When it comes to immobilization, most of the fractures will be stabilized by plaster of Paris, and that has found to be one of the causes for complex regional pain syndrome, where winding of the plaster of Paris tight enough is going to trigger sympathetic nervous system for the person. When it comes to peripheral nerve and dorsal roots, trauma and injury to brachial plexus and other peripheral nerves is one of the cause for peripheral nerves and dorsal roots. During this, when you see brachial plexus injury, the injury is going to happen either by traction or either by a blunt trauma where there is a sharp object is going to impinge the structure. So now during this, if there is any traction, patient is going to have stretched plexus, ultimately leading into neuropathic pain. And when it comes to central nervous system, CRPS can follow stroke, tumors, traumatic brain injuries. When it comes to viscera, it can follow after myocardial infarction. And idiopathic is spontaneous, and there is no definitive cause for a person to end up in CRPS. It could be idiopathic, and the percentage of spontaneity is around less than 10%. When it comes to signs and symptoms of CRPS, there will be a constant pain even at rest. People with CRPS or RST will have severe pain even during rest, either in supine lying or just simply sitting. An area of pain is always larger than the area of injury. For example, if a person has a distal and radius fracture, the fracture is only in the distal and radius area, but the pain could be felt in the shoulder region. Likewise, if any mortise fractures, people will have perception of pain till their thigh region. And there will be a limited range of motion associated with CRPS, either in both upper limb as well as lower limb. And people often complain of pain as a burning type of sensation which they are going to perceive even at rest. And there will be nail growth changes and pain for a non-noxious stimuli called as aldonia. So even for a non-noxious stimuli, they are going to perceive that as pain, and they are going to complain of pain which is excruciating levels. When it comes to clinical features, there are negative symptoms, positive symptoms, autonomic symptoms, motor or trophic symptoms. When it comes to negative symptoms, there was a study done by Jason et al. It's a review literature of neuropathic pain. It's a new perspective. He has defined negative symptoms as sensory symptoms. All this aldonia which a patient is going to complain is going to fall in negative symptoms. Positive symptoms are hyperalgesia, and hyperesthesia is going to be in positive symptoms. And autonomic symptoms are vasomotor, where the person is going to have temperature changes and color changes, and pseudomotor is edema and sweat changes. When it comes to motor or trophic changes, motor is range of motion restriction and dysfunction in upper limb as well as lower limb, and they will have dystonia and other activities. And when it comes to trophic changes, they will be having nail changes, hair growth changes, and temperature and other changes. So now complex regional pain syndrome, there is a synonym called as STAM, where it is sensory, trophic, autonomic, motor and pain. In sensory, aldonia is prevalent, hypo or hyperalgesia is prevalent, and hypo or hyperesthesia is prevalent. When it comes to trophic, skin, hair and nail growth changes are prevalent and can be seen visually. And autonomic, people will have swollen upper limb as well as lower limb. Edema is going to be prevalent, and there will be either profuse sweating or their sweating is going to become lower. When it comes to motor, there will be reduced muscle strength, ultimately leading into weakness, and they will be ending up in a contracture because of reduced mobility in the later phases of the condition, and there will be atrophy because of non-use of the extremity which is involved, and there will be pain prevalent. So now in these two pictures, we can see there is a severe edema the person is having in the lower limb, and this ultimately led into some skin changes where we are going to see a red and glossy skin. When it comes to natural history, transition of CRPS occurs in 3 phases. First phase is acute or warm phase, and second phase is intermediate or cold phase, and third phase is chronic phase. In acute or warm phase, edema, warm, red and glossy skin is going to be prevalent, and this was seen in the second picture where there is edema as well as red and glossy discoloration of the person. And when it comes to intermediate phase, cold, hyperhidrosis and cyanosis is prevalent, and we can see bluish discoloration of either upper limb or lower limb. And in chronic phases, there will be severe motor and trophic changes. In this table, these 3 stages have been categorized, and time frame has been clearly. And when it comes to acute stage, affected limb will be swollen and it will be red, and people will complain of burning type of sensation from the time of injury. And there will be increased diaphoresis of affected limb, and all symptoms are near the site of the original injury. In acute phase, we don't see the inciting event disproportionate, it is going to be the same. It is going to be localized only to the area of injury. And the time frame for this is within weeks of injury, we can see this characteristics in a person. When it comes to dystrophic stage, skin of upper limb is cool and diaphoretic, and pseudox atrophy can be seen in X-ray. So if you take an X-ray in the second stage of CRPS, so there will be pseudox atrophy that can be seen in an X-ray. And pain occurs throughout the limb, just not at the site of injury. This is an important clinical feature where we can diagnose or say a person is having a second stage of CRPS. And this will happen within a frame of months. When it comes to atrophic changes, skin becomes pale and it becomes shiny. And atrophy of muscles and bones can be seen in the affected limb, and pain can be constant even with treatment. And even with treatment means even if a person is having pharmacological or other therapies, people will perceive continuous pain when they are having CRPS in the atrophic stage or third stage of CRPS. And this may be from months to years. So the IISP has given CRPS 1 and 2 taxonomy. They have given a set of rules how to identify CRPS 1 and CRPS 2. So when it comes to CRPS 1 or reflex sympathetic dystrophy, so the first one is inciting noxious event or a cause of immobilization. So there will be an event of trauma where a person is having pain due to trauma, or because it is caused because of immobilization. Most of which we use plaster of Paris or other things to immobilize a person segment to be kept in the position. And second point is continuous pain or allodynia or hyperalgesia is present and the pain is disproportionate to any inciting event. So initially with an example, if we have CRPS to be found out or to be diagnosed, people should have an inciting event which is going to be smaller than the area of pain. Distal and fracture, for example, in this event the only area is going to get affected is near the wrist, but people will end up in pain over till the shoulder region where they will have a larger surface area of pain. And evidence at some point of edema will be present and changes in skin blood flow and abnormal pseudomotor activity in the region of pain will be seen. The diagnosis is excluded by existence of conditions that would otherwise account for the degree of pain and dysfunction. The fourth one is very important because there are few conditions which are going to mimic CRPS. For example, people with fibromyalgia, people with other sympathetic conditions where they are going to show similar characteristics of CRPS. So if there is any event or if there is any condition which was not diagnosed apart from CRPS, so people will commonly take the condition as CRPS and they'll think it is a neuropathic pain. So all differential diagnosis has to be made and there should be no any other condition which is going to overlap CRPS. And when it comes to CRPS type 2 or causalgia, the presence of continuous pain, allodynia or hyperalgesia after the nerve injury, and it doesn't necessarily limit to the distribution of the injured nerve. For example, if there is any peripheral nerve injury on the lateral aspect of hand, which is over your median nerve, and ultimately people can perceive it to the radial part of the hand also. So the inciting event is smaller, but the area of pain is going to be higher, which is not only in the distribution of the nerve, it is going to be throughout the upper limb. Evidence of some time of edema and skin changes and blood flow can be seen, and abnormal pseudomotor activity in the region of pain is visible. And the diagnosis is excluded by the existence of conditions that would otherwise account for degree of pain and dysfunction. Likewise, any other condition which is overlapping with CRPS type 2, any peripheral nerve injuries or any other condition which is going to mimic CRPS have to be ruled out. After ruling out itself, we are going to say it is CRPS type 2. And when it comes to CRPS type 2, all the above mentioned three criteria, 1, 2 and 3 has to be satisfied. In case if a person is not satisfying any of these criteria, we can't grade him as CRPS type 2. So in 1994, when IASP has proposed criteria for CRPS 1 as well as CRPS 2, there are many other conditions which are overlapping and ultimately led into falsely diagnosing people to have either CRPS 1 and CRPS 2. So in 2003, there is a congress that has held in Budapest, and in Budapest they have taken criteria that has to be validated, and they found out they have come with consensus saying that of all the criteria, so people perceive these 4 conditions or these 4 signs and symptoms, they will be put up in CRPS 1 or 2. So now Budapest criteria, which was held in 2003, so the main aim is to identify people having CRPS. So Budapest criteria for CRPS has to follow all the criteria that has to be met. So the first one is the patient has continuous or continuing pain that is disproportionate to any inciting event. So the inciting event, the area of injury and the area of pain right now should be always disproportionate, and it should be always higher. And the patient has at least, or the patient has to have at least 1 sign or 2 in more of the categories that has mentioned below. The patient reports at least 1 symptom in 3 or more of the categories which were presented below, and no other diagnosis can better explain these signs and symptoms. If there is no other diagnosis which was showing the patient is having pain or any other changes, then you can grade him as CRPS. So when it comes to the criteria, there are 4 essential criteria. There are sensory changes, that is allodynia. People will perceive non-noxious stimuli as noxious stimuli during this event, and pain to touch or temperature sensation or deep somatic pressure or joint movement. So these are the features that you can see in sensory category. And there will be hyperalgesia to pinprick. So whenever a person is CRPS, if there is any pinprick happening, there will be hyperalgesia and he will perceive the pain as higher. When it comes to vasomotor changes of category 2, there will be temperature asymmetry and on skin color changes or skin color asymmetry. So when it comes to temperature asymmetry, there will be an increased temperature in the initial phase, that is inflammatory phase of CRPS 1. When it comes to warm phase, when it comes to cold phase or intermediate phase, it is going to be lower in temperature. So based on this rise in temperature to lower temperature, we can say person is having a CRPS from inflammatory phase to cold phase. And pseudomotor or edema will be seen, limb will be swollen, and sweat changes and sweat asymmetry is going to be felt. So in this pseudomotor changes, sweat could be profusely sweat. People can profusely sweat in the extremity which has been affected. It could be either upper extremity, hand, or lower extremity, foot. So there will be hyperhidrosis in the situation, or there will be hypo. So people will have profuse sweating, or people will not sweat at all, ultimately leading into sweating asymmetry, and the skin will become patchy and scaly. So when it comes to motor atrophic, because of pain, people will have a reduced range of motion where they are not going to do an active range, and ultimately leading into range of motion restriction. And this leads into motor dysfunction. Ultimately people will have weakness, they'll have tremor, and they'll have dystonia on both sides. And atrophic changes, there will be hair, nail, and skin growth. So Budapest criteria, after formulating all these four aspects of both sign and symptoms, the specificity has grown up. It has gone to 0.95. So let us talk about pathophysiology. Pathophysiology, there are so many factors that affect a person to end up in CRPS or aggravate their pain or neuropathic pain. So when it comes to the first thing, there is neurogenic inflammation, where their inflammation process is going to take place as soon as a person is having injury. So now in this picture we can see there is a sensory neuron that has both TRPV1 and TRPA2. So now if there is any noxious stimuli that has been given to a person because of any other factor or any injury to the patient or patient extremity, either to upper limb or lower limb, there will be an increased secretion of neuropeptides. Of all the neuropeptides, substance P neuropeptide is having something called as vasoconstriction, or it is going to increase the effect of inflammatory changes. So now after production of neuropeptide substance P, it is going to increase the production of mast cells, and it activates microglia, and it activates T lymphocytes and astrocytes. So when it comes to mast cells, it produces histamine, which is an inflammatory process, and serotonin. And because of this, there will be a pro-inflammatory cytokinesis, and ultimately leading into increased pain. So this neurogenic inflammation, once it is triggered, it is non-never-ending process, it is going to increase. So because of these substances and because of these neuropeptides, the people will perceive as pain higher and higher. When it comes to altered cutaneous innervation, continuous inflammation of the peripheral nerves will lead into density loss of A delta and C fibers, ultimately losing their integrity, and there will be new cutaneous alteration that is going to happen. When it comes to sensitization, every sensation needs something called as threshold. So now during sensitization process, there will be a lower threshold for a person to perceive in pain, ultimately leading into aldonia. During this process, people will perceive a very minimal threshold of sensation as pain, ultimately leading into something called as altered sensation. They will be having aldonia, where they will perceive non-noxious stimuli higher as a noxious stimuli. When it comes to brain plasticity, there will be a reorganization of representation of brain. So when we come to peripheral nerve injury, or when we come to any peripheral musculoskeletal structures injured, there will be an increased peripheral input towards the spinal cord, and it goes to the higher mental areas of brain. So based on this, there will be an increased peripheral sensitization of the extremity, either upper limb or lower limb. And from your spinal cord, it goes to the centers of brain. Ultimately, this noxious stimuli is going to be staying there for higher time, ultimately leading into central sensitization. So now the brain is going to sensitize more. Even a small increase in input in the peripheral region is going to send impulses to the brain, and there will be an increased awareness of noxious events. It is going to be there for some time. And this changes the processing at the brain and spinal cord level, and ultimately leading into secondary hyperalgesia or aldonia. Your sympathetic nervous system is going to be the other cause, where it is going to give higher function and higher inputs to the peripheries when there is any stimuli triggered. So now when it comes to sympathetic sensory coupling, so this is an important area where your sympathetic nerves, which are kept near your dorsal root ganglia, which has C fibers, they are both efferent as well as efferent. So now this near dorsal root ganglia, during injury, it is going to show something called as new nervous sprouting, and it is going to make a basket of new sprouted neurons. cells. Ultimately, there is an upregulation of your pain nociceptors going to happen. It is going to be kept in that particular area. Ultimately, this is going to be a continuous coupling of your sympathetic nervous system to your nociceptor upregulators, and ultimately leading into a sympathetic sensory coupling, making the patient very sensitive to pain even the stimulus is very minimal. And this is going to prolong, it is not going to reduce, it is going to increase its intensity and ultimately leading into pain. And genetics were also found to be an important aspect of CRPS, and people will have pain because of genetic factors. And when it comes to psychology, as we know, pain is not only biological, it is psychological as well as sociological. So when people have psychological aspects or people with psychological issues, they may end up in pain. So that is also one primary cause for a person to have CRPS. So when it comes to mechanism of RST, as I told you before, there will be an original injury initiates at pain impulse carried by sensory nerves to the central nervous system. Now your brain is going to activate sympathetic nervous chain over the spinal cord, and the pain impulses in turn triggers the impulse in sympathetic nervous system, which in turn goes to the original site of pain. And this triggers inflammatory process that is going to happen in that particular area. And the triggered process at another response establishes a cycle of pain and swelling, and this is going an ongoing process. There is a no end for this. It is going to be pain inflammatory cycle, ultimately leading your patient to end up in a resulting condition with burning sensation called as CRPS. So now this table gives us all the summary and the possible pathophysiological mechanisms that may contribute to CRPS. So they are altered cutaneous innervation, central sensitization and peripheralization. Initially there will be peripheral sensitization of a person during the area of injury, and which will lead into central sensitization. And altered sympathetic nervous system function will be happening because continuous sympathetic chain in your spinal cord is going to get activated, which is going to activate the person's inflammatory process. And circulatory catecholamines is also going to be present. There will be exaggerated catecholamine response because of receptor upregulation. It is going to be nociceptors upregulation. And inflammatory processes or inflammatory factors are going to be produced continuously, and this is going to activate and this is going to maintain the inflammation whole the time. And brain plasticity, because of reduced presentation in CRPS affected lips, there will be somatosensory cortex alterations, and people will have brain plasticity and they will try to neglect the area of pain. Genetic and psychological factors or other factors that may contribute a person to have CRPS. When it comes to diagnostic tests, there are three aspects of diagnostic tests. One is imaging and imaging techniques, other one is autonomic function, and third one is going to be the others. When it comes to imaging technique, radiographs are going to be used in people with CRPS, and radiographs will show you something called as severe osteopenia, and there will be bone scans available, and you are going to see bone scans here. And infrared thermometry is a device which a person is going to be seated normally, and the therapist who is evaluating is going to project the infrared thermometer over the affected area, and you are going to see temperature changes in the area. And resting sweat output is nothing but people will be seated in normal area, and you are going to see whether they are sweating profusely or normal. And now conduction velocities is nothing but it is it's just used to see the nerve afferent as well as afferent activity. And somatosensory evoked potentials, quantitative sensory testing, and sympathetic nerve blocks can be given to your person to find whether he has CRPS 1 or 2. When it comes to nerve conduction velocity test, it is a pain-provoking test. So in the initial phases or the inflammatory phase, there should be no nerve conduction velocities given to your patient. And the safe side is going to see something called as infrared thermometry, where you are going to see the heat and cold of both upper limb as well as lower limb. And people with lower temperature changes or lower temperature recording in upper limb as well as lower limb can be graded as stage 2 of CRPS. When it comes to patient care, there are 4 pillars of patient care. This has to be followed by everyone, because treating CRPS is not only highlight it is also multidisciplinary. So there are 4 important aspects of treating CRPS. The first one is pain relief, and it is by medication and other procedures. And second one is surgical and vocational therapies or rehabilitation process. And third one is going to be your psychological interventions. And ultimately patient has to have an idea of what his condition is, and there should be an information about patient's condition, and he should have an education about his management, self-management. So now in this table, so there was given as 4 important aspects. So first one is diagnosis as care continuum. So you are going to have psychological interventions, medical interventions, and psychotherapies, physical therapies, patient control. And ultimately when everything is summed up to the patient, they are going to have something called as return to function. In case if any of these interventions fail, patient will have continuous perception of pain and they can't return to the function like normal. And thank you.